Okay, Assalamu alaikum. I think we have a good enough number to start the lecture. Today's lecture is going to be about the pathophysiology of coronary artery disease, presented by Abdullah Latabi. Whenever you have time, Abdullah, you can start, please.
السلام عليكم. الصوت واضح؟
عليكم السلام تفضل.
First of all, I'm trying to call Dr. Al-Baradi, but I think he's in OR still. He did not finish. So maybe he'll join us later on. So I'm going to start. Assalamu alaikum. This is Abdullah Tabi, R3 cardiac surgery resident at King Fahd Medical City. Today, inshallah, I'm going to present pathophysiology of coronary artery disease. So I will talk about brief introduction about coronary artery disease, risk factor for coronary artery disease, pathogenesis of atherosclerosis, role of acute plaque changes, and progression of ischemic myocardial injury, tissue repair following myocardial infarction. So as introduction, coronary artery disease is a major cause of death and disabilities in developed countries. Although coronary artery disease mortality rates worldwide have been declined over the past 4 decades, coronary artery disease remained responsible for about 1/3 or more of all deaths in individuals over the age of 35. It has been estimated that nearly 1/2 of all middle-aged men and 1/3 of middle-aged women in the United States will develop some manifestation of coronary artery disease. Myocardial ischemia occurs when perfusion via coronary flow is inadequate to meet metabolic needs, thus interfering with both the cellular delivery of oxygen and nutrients to cardiac myocytes and the removal of waste products. Myocardial ischemia most often results from obstruction or narrowing of the coronary artery secondary to atherosclerosis. There are some non-atherosclerotic epicardial coronary artery obstruction also can occur in autoimmune disease like SLE and rheumatoid arthritis, progression of systemic sclerosis like scleroderma, vasculitis like Kawasaki disease, fibromuscular dysplasia, and also as a result of dissection spasm, embolism, or some drugs like cocaine. Decreased coronary flow leading to global hypoperfusion and myocardial ischemia can occur during cardiopulmonary bypass. Ischemia can also result from increased cardiac demand secondary to exercise, tachycardia, hyperthyroidism in case of hyperdynamic circulation, or ventricular hypertrophy or dilatation. Moreover, the effects of ischemia are potentiated when oxygen supply is decreased secondary to anemia, hypoxia, or cardiac failure. Risk factors, we have non-modifiable risk factor and modifiable risk factor. Non-modifiable, like increasing in age, male sex, family history, and ethnic origin. Modifiable risk factors, smoking, hypertension, dyslipidemia, diabetes, obesity and metabolic syndrome, psychological stress, high calorie, high fat diet, and physical inactivity. Stopping smoking carries almost immediate benefit, and although the long-term benefits are greatest in those who stop smoking before the age of 40s, stopping in middle age also beneficial. Now, before we talk about pathogenesis, we'll just brief about histological structure of the blood vessels. We have 3 structures: intima, which is the most linear structure from in to out, usually covered by endothelium. Then the elastic, the media structure, mostly muscular structure, rich by smooth muscle cells, and the adventitious structure, which is mainly collagenous fiber, collagen tissue. Now, atherogenic process characterized by dysfunction of endothelial lining of the vessels, inflammation of muscular wall, of the vascular wall, and builds up of lipid, cholesterol, and inflammatory cells in the vessel wall, and accumulation of cellular debris within the intima and subintimal layers of the vessels. So endothelial dysfunction causes vasoconstriction due to decreased nitric oxide, increased permeability to lipoproteins, and expression of tissue factors leading to thrombosis. Expression of certain injuries induce adhesion molecules leading to adherent of platelet and inflammatory cells. Linear fatty streak, which is the first step in the first phase of atherosclerosis, which is focal intimal thickening caused by deposition of lipid-filled macrophages and smooth muscle cells. Fibrolipid plaque, consisting of those lipid-laden cells, an inflammatory core and cholesterol deposits encased by fibrous cup, resulting in laminar narrow. So this is a process. Usually, a first step by endothelial dysfunction lead to decreased nitric oxide and exposure of subendothelial layers, which attract the platelet and monocytes. So second step, monocyte adhesion and lipid cells adhesion and migration to subendothelial layers. After that, those lipid cells are phagocytosed by these monocytes and conversion into foam cells, which is mainly macrophages phagocytosed by lipid cells. Then smooth muscle proliferation and immigration from subendothelial layer into intralaminar layers. After that, progression of these forming extracellular matrix, which form the fibrous cup, a result of rupture or injury to this fibrous cup leading to thrombus formation. Again, the same fatty streak, which is intracellular lipid accumulation, intermediate lesion, intracellular lipid accumulation, and extracellular lipid proteolysis. Atheroma, intracellular lipid accumulation, and large extracellular lipid mass inflammation. Fibroatheroma, large lipid core fibrosis, and calcification of plaque, inflammation, then complicated lesion by endothelial lesion, hematoma, thrombi, inflammation. Blood flow through arteries causes local generation of fluid shear stress, which influences the biology of underlying endothelial cells. High laminar flow from blood flowing quickly through the straight vessels favor the generation of nitric oxide itself to maintain the functional integrity of the vessels. In contrast, low shear caused by turbulent flow causes dysfunction of the underlying endothelial cells, which facilitates initiation and progression of atheroma. This helps explain why plaque are found more commonly at the site of vessel branches or curvature, which experience more dramatic and abrupt changes and irregularities of direction and velocity of blood flow. Clinical manifestations of advanced coronary artery atherosclerosis occur through encroachment of the lumen, leading to progressive stenosis or to acute plaque disruption and thrombosis. In the absence of significant coronary blockage, myocardial perfusion is adequate at rest, and compensatory vasodilation provides flow reserve that's more than sufficient to accommodate increased metabolic demand during vigorous exertion. When the coronary laminar cross-sectional area is decreased by approximately 75%, blood flow becomes limited during exertion. With 90% reduction, coronary flow may be inadequate at rest. However, occlusions that develop slowly might stimulate formation of collateral vessels that protect against distal myocardial ischemia. Aneurysms may form secondary to atherosclerosis as a result of destruction of media beneath the plaque, a process most commonly in the aorta and the large vessels, where the plaque does not easily cause obstruction. Role of acute plaque changes. The conversion of chronic stable angina or asymptomatic state to acute coronary syndrome is dependent on the dynamic vascular changes, such as fracture or rupture of fibrous cup, exposing deep black constant and subsequent thrombus, whether occlusive or partial, sometimes with emboli. Less commonly, the change is erosion or ulceration of the fibrous cup, setting the stage for platelet aggregation and mural or total thrombosis. So this is a spectrum of ischemic heart disease. Usually when the narrowing is mild and there is no the cross-sectional laminar area of the coronary is greater than 75%. Usually it's asymptomatic state of chronic angina. In case of acute coronary syndrome and unstable angina, there is a progressive mild to moderate narrowing of the artery. Also, mainly chest pain, more than 30 minutes, can occur at rest, but there's no ECG or troponin leak. In non-STEMI, moderate to severe narrowing of the coronary and characterized by progressive chest pain with evidence of myocardial necrosis, elevated troponin, and sometimes normal ECG. In case of STEMI, there is a progression of chest pain, usually characterized in the coronary by complete occlusion or complete obstruction of the coronary artery due to the either plaque occlusion by thrombus or aneurysm or rupture of the plaque. Plaques having high propensity to rupture are known as vulnerable plaque. Those plaques are characterized by having a thin collagenous fibrous cup and few smooth muscle cells that produce the collagenous matrix and contain many macrophages producing matrix metalloproteinase, which is the enzyme that degrades the collagen that leads to the strength of fibrous cup. 3 contain large areas of foam cells, extracellular lipids, and necrotic debris. So inflammation might contribute to coronary thrombosis by altering the balance between prothrombotic and fibrinolytic properties of the endothelium. There is evidence that lipid lowering by diet or drugs such as statins reduce the accumulation of macrophages expressing matrix degrading enzymes and thereby stabilize the plaque by increasing the thickness and the strength of fibrous cup. Now, progression of ischemic myocardial injury. Usually, the approximate time of onset and recognition is a key feature of ischemic myocardial injury. So, from the event, the onset of the event to the changing from aerobic metabolism to anaerobic metabolism usually occurs within seconds. That's why lactate increase. Loss of contractility less than 2 minutes. ATP reduced up to 50% of the normal within 10 minutes, up to 10% of normal within 40 minutes. Irreversible cell injury between 20 to 40 minutes, and microvascular injury more than 1 hour. This figure shows the relation between lactate level and ATP in terms of conversion from aerobic metabolism to anaerobic metabolism in cardiac myocytes. So usually within 15 to 20 minutes, there is decrease in ATP and accumulation of lactate, which reaches the maximum within 40 minutes. Figure number 2 shows the myocardial injury potentially reversible approximately 20 minutes after the onset of event in most, even most severe ischemia. Thereafter, the progression loss viability occurs, which is completed by 6 to 12 hours, and the benefits of reperfusion and greatest when it's achieved early. Coming for tissue repair following myocardial infarction, the inflammatory reaction is characterized by early exudation of polymorphic nuclear leukocytes seen after 6 to 12 hours and maximum within 1 to 3 days. Subsequently, 3 to 5 days, the infiltrate consists of predominantly of macrophages that remove the necrotic tissue. Then collagen production combined by new vascularization begins approximately 7 to 10 days at the margin of preserved tissue. Ultimately, the infarcted tissue is replaced by dense collagen scar, which is fully mature by about 6 to 8 weeks. This was my presentation. Any question?
Okay, thank you, Abdullah. Very informative presentation. If we're not going to have any questions now, we can take a break for 5 minutes or 10 minutes and then resume back with the second lecture. Okay, so the second lecture is going to be about myocardial infarction and indication for revascularization by Dr. Faris Abunanin. Faris, if you're ready, please proceed.
السلام عليكم.
Salam.
Best, I'm trying to contact Dr. Mus'ab to see if he can attend with us.
Take your time. Faris, you can start a few slides till he finds the time to join us.
Okay, I'm trying to contact him, but he's not responding. Maybe he's in a meeting. I will start. Maybe he will join us later.
Thank you.
Thank you. Hello? My voice clear?
Yes, go ahead.
Okay, Assalamu alaikum. Good afternoon, everyone. I'm sorry for the delay, but Dr. Musab just contacted me. He will attend now with us. I am Faris Abulainen. I'm cardiac surgery resident at King Fahd Hospital in Jeddah. And today I will talk about myocardial infarction and the indication for revascularization. Okay. Oh my God. These are my objectives. I will go through introduction first. I will talk about MI and its type, pathophysiology, etiology, prognosis, clinical presentation, workup, and lastly, guidelines. Okay, myocardial infarction is the irreversible death of heart muscle secondary to prolonged lack of oxygen supply. And we see in this picture acute myocardial infarction. In this case, the infarct is diffuse, the hemorrhagic. There is a rupture track through the central of this posterior left ventricular transmural infarct. And the mechanism of death was hemopericardium. Myocardial infarction usually results from an imbalance in oxygen supply and demand, which is most often caused by plaque rupture with thrombus formation in the epicardial coronary artery, resulting in acute reduction of blood supply to a portion of myocardium. Although the clinical presentation of a patient is a key component in the overall evaluation of patient with MI, many events are either silent or not clinically recognized by patients, families, and healthcare providers. The appearance of cardiac biomarkers in the circulation generally indicates myocardial necrosis and is a useful adjunct to diagnosis. MI is considered part of a spectrum referred as acute coronary syndrome. The acute coronary syndrome continuum, representing ongoing myocardial ischemia or injury, consists of unstable angina, non-ST segment elevation MI, and non-ST segment MI or non-ST segment elevation ASS and ST segment elevation MI. Patient with ischemic discomfort may or may not have ST segment or T wave changes denoted on the ECG. ST elevation seen on the ECG reflects active and ongoing transmural myocardial injury. Without immediate reperfusion therapy, most patients with STEMI develop Q waves, reflecting a dead zone of the myocardium that has undergone irreversible damage and death. And those without ST elevation are diagnosed either with unstable angina or non-ST elevation SAS, and can be differentiated by the presence of cardiac biomarkers. Both these conditions may or may not have changes on the surface ECG, including ST segment depressions or T wave changes. MI also may lead to impairment of systolic or diastolic function and increase predisposition to arrhythmia and other long-term complications. Okay. Coronary thrombolysis and mechanical revascularization have revolutionized the primary treatment of acute MI, largely because they allow salvage of the myocardium when implanted early after the onset of ischemia. The modest prognostic benefit of an opened infarct-related artery might be realized even when recanalization is induced only 6 hours or more after the onset of symptoms. That is when the salvage of the substantial amounts of jeopardized ischemic myocardium is no longer likely. The opening of an infarct-related artery might improve ventricular function and collateral blood flow, prevent ventricular remodeling, as well as decrease infarct expansion, ventricular aneurysm formation, and left ventricle dilation, and reduce late arrhythmia associated with ventricular aneurysm and mortality. Evidence suggests benefit from the use of beta blockers and angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, and statins. Okay. MI and its type. As I mentioned before, myocardial infarction is defined pathologically as the irreversible death of myocardial cells caused by ischemia. Clinically, MI is a syndrome that can be recognized by a set of symptoms, and chest pain being the hallmark of these symptoms in most cases, supported by biochemical laboratory changes, ECG changes, or finding on imaging modalities able to detect injury and necrosis. According to the third universal division of MI implemented by the Joint Task Force from the European Society of Cardiology, American College of Cardiology Foundation, and American Heart Association, and the World Heart Federation, MI is diagnosed with either of the following two criteria are met. One, a detection of an increased or decreased in cardiac biomarker value, prefer using cardiac troponin with at least one value above the 99th percentile of the upper reference limit, and with at least one of the following findings. Symptoms of ischemia, new or presumed new significant ST wave changes or new left bundle branch block, development of pathologic Q waves on the ECG, imaging evidence of new loss of viable myocardium or a loss or a new regional wall motion of normality, and identification of an intracoronary thrombus by angiography or autopsy. Secondly, cardiac death with symptoms suggestive of myocardial ischemia and presumed new ischemic changes or injury or new bundle branch block on ECG, but death occurred before cardiac biomarkers levels were obtained or before cardiac biomarkers value would be increased. Okay. Types of MI. The Joint European Society of Cardiology and American College of Cardiology and American Heart Association and World Heart Federation Task Force further classified MI into 5 types on the basis of the underlying cause. Type 1, spontaneous MI, which is related to atherosclerotic plaque rupture, ulceration, fissuring, erosion, or dissection with intraluminal thrombus in one or more of the coronary arteries, leading to decreased myocardial blood flow or distal platelet emboli, and thereby resulting in myocyte necrosis. The patient may or may not have underlying obstructive coronary artery disease. Type 2, MI secondary to ischemic imbalance, which is MI consequent to increased oxygen demand or a decreased supply. For example, coronary endothelial dysfunction, coronary artery spasm, coronary artery embolism, tachyarrhythmia, bradyarrhythmia, anemia, respiratory failure, hyper or hypotension. Type 3, MI resulting in death when biomarker values are unavailable, which is sudden unexpected cardiac death before blood samples for biomarkers could be drawn or before their appearance in the circulation. Type 4A, MI related to PCI, which is elevation of biomarkers, cardiac troponin, to more than 5 times the 99th percentile of upper reference limit in patients with normal baseline values, or a rise of values over the 20% of baseline values are elevated but stable or falling. In addition, symptoms suggestive of myocardial ischemia, new ischemic ECG changes or new bundle branch block, angiographic loss of patency of a major coronary artery or a side branch or resistant slow flow or no flow or embolization, or demonstration of new loss of viable myocardium or new regional wall motion abnormality by cardiac imaging. Type 4, MI related to stent thrombosis, which is MI associated with stent thrombosis as detected by coronary angiograph on autopsy in the setting of myocardial ischemia in combination with a rise and or fall of cardiac biomarkers with at least one value above the 99th percentile of upper reference limit. Lastly, type 5, MI related to coronary artery bypass grafting, which is elevation of cardiac biomarkers more than 10 times of the 99th percentile of the upper reference limit in patients with normal baseline coronary troponin values. In addition, either a new pathologic Q wave or new bundle branch block, angiographic documented new graft or native coronary artery occlusion, or evidence of new loss of viable myocardium or new regional wall motion abnormalities by cardiac imaging is required. Okay. Pathophysiology. As mentioned with our colleague Dr. Abdullah Al-Afia, I will talk briefly about pathophysiology in relation to MI. Myocardial injury and myocardial cell death for a normal heart to continue to function and to steadily pump blood efficiently to meet the demands of the body. It needs to have a constant supply of oxygen and nutrients provided mainly by the coronary circulation. Myocardial ischemia happens if blood supply to the myocardium does not meet the demand. If this imbalance persists, it triggers a cascade of cellular inflammatory and biomarker events, leading eventually to irreversible death of heart muscle resulting in MI. Evolution of MI and ventricular remodeling. The spectrum of myocardial injury depends not only on the intensity of impaired myocardial perfusion, but also on the duration of and the level of metabolic demand at the time of the event. Severe loss of the ability of the heart muscle to contract can be observed as early as within 60 seconds. Resistance of oxygen deprivation to the myocardium through the cessation of blood supply will lead to irreversible myocardial injury within 20 to 40 minutes and up to several hours, depending on the several factors, including existing metabolic state of the body and resistance and presence of coronary collateral blood flow. Typical MI initially manifests as coagulation necrosis that ultimately followed by healing process characterized by formation of myocardial scarring known as myocardial fibrosis. This mechanism allows a significant architectural changes to the composition, shape, and contractile function of the myocardium, especially in the left ventricle, which is the major contributor to the contractile function of the heart. Eventually, the left ventricle dilates and changes into more spherical shape in a process known as ventricular remodeling. Despite being an irreversible process, Ventricular remodeling is a regulated process. Therefore, a specific treatment strategies and agents should be used in acute management in order to reduce the occurrence and severity of ventricular remodeling. Okay. Reperfusion injury. In some occasions, restoration of blood flow to the damaged myocardium triggers further ischemic cellular changes or damage. This paradoxical effect is known as a reperfusion injury. This process involves a complex interaction between oxygen-free radicals and intracellular calcium, leading to acceleration of myocardial damage and death, microvascular dysfunction, and fatal arrhythmia. The role of nitric oxide, which is an endothelium-derived relaxing factor, as a cardioprotective agent against reperfusion injury, has been demonstrated as nitric oxide works to inactivate oxygen-free radicals and therefore ameliorating the process of the reperfusion injury. Despite the improved understanding of the process of reperfusion injury, there are no specific therapies to prevent it. Stent and hibernating myocardium. Stent myocardium is a condition of transient left ventricular dysfunction following an ischemic event to the myocardium. It occurs if coronary blood flow was impaired for a brief period of time, 5 to 15 minutes. We usually stent myocardium persists for hours or days following the re-establishment of coronary blood flow. However, prolonged exposure of the myocardium to an ischemic state results in an impairment of its contractile function, which can be partial or complete. This is known as myocardial hibernation, and it is reversible with revascularization. Both myocardial stenting and hibernation occur because of loss of essential metabolites required for normal myocardial contractility, such as adenosine, which is needed for adenosine triphosphate dependent contraction. Blake. The atheromatous plaque responsible for acute MI develops in a dynamic process in multiple stages, starting with arterial intima thickening, which consists of vascular smooth muscle with very minimal or non-inflammatory cells. This process can be observed soon after birth. Subsequently, the formation of fibrous cap theroma occurs, which has a lipid-rich necrotic core that is surrounded by fibrous tissue. Eventually, a thin cap fibrotheroma develops. This is also known as vulnerable plaque, which is composed mainly of large necrotic cores separated from the vascular lumen by a thin fibrous cap that is infiltrated by inflammatory cells and deficient of smooth muscle cells, making it vulnerable to rupture. The process of acute coronary thrombosis leading to ACS involves the pathogenic mechanism of plaque rupture and less frequently plaque erosion. The Brazilia's heart study group indicates that changes in high-density lipoprotein, HDL, during an MI might alter the anti-atherogenic function of HDL to transport lipids from arterial walls. The investigators noted a stimulus decrease in lipid transfer in HDL and the capacity to efflux cholesterol from cells occur in acute a period after NMI. Okay. In nested case study control that evaluate the association of plasma metabolic markers with the risk of incidence of MI, ischemic stroke, and intracerebral hemorrhage, investigators found positive association of lipoprotein and lipids with MI and ischemic stroke, but not with intracerebral hemorrhage, as well as a positive association between triglyceride concentration and MI. Except for small HDL, there was also an inverse association of HDL particles with MI and inverse association of cholesterol in large HDL with MI and ischemic stroke. The study included 912 patients with MI, 1,146 with ischemic stroke, and 1,138 with intracerebral hemorrhage, and 1,466 control subjects. Okay, etiology. Atherosclerosis is the disease primarily responsible for most acute coronary syndrome cases. Approximately 90% of myocardial infarction results from an acute thrombus that obstructs an atherosclerotic coronary artery. Plaque rupture and erosion are considered to be the major triggers and for the coronary thrombosis. Following plaque erosion or rupture, platelet activation, aggregation, coagulation pathway activation, and endothelial vascularization occur, leading to coronary thrombosis and occlusion. Within the coronary vasculature, flow dynamics and endothelial shear stress are implicated in the pathogenesis of vulnerable plaque formation. A large body evidence indicates that in numerous cases, culprit lesions are stenosis of less than 70% and are located approximately within the coronary tree. Coronary atherosclerosis is especially prominent near branching point of vessels. Culprit lesions that are particularly prone to rupture are atheromas containing abundant macrophages, a large lipid-rich core surrounded by a thin fibrous cap. Okay, non-modifiable risk factors for atherosclerosis include A6 family, history of premature coronary heart disease, male pattern baldness. Modifiable risk factors include smoking or other tobacco use, hypercholesterolemia, hypertriglyceridemia, including inherited lipoproteins, dyslipidemia, diabetes, hypertension, obesity, psychosocial stress, sedentary lifestyle, reduced consumption of fruits or vegetables, poor oral hygiene, type A personality, elevated homocysteine levels, presence of peripheral vascular disease. MI can also occur for causes other than atherosclerosis. Non-atherosclerotic causes of MI include coronary occlusion secondary to vasculitis, ventricular hypertrophy like left ventricular hypertrophy, hypertrophic cardiomyopathy, coronary artery emboli secondary to cholesterol, air, or the products of sepsis, coronary trauma, primary coronary vasospasm like variant angina, drug use like cocaine, amphetamine, or ephedrine, arthritis, coronary anomalies included aneurysm of coronary arteries, factors that increase oxygen requirement, such as heavy exertion, fever, or hyperthyroidism, factors that decrease oxygen delivery, such as hypoxemia or severe anemia, aortic dissection with retrograde involvement of the coronary arteries, respiratory infections, particularly influenza. In addition, MI can result from hypoxia due to carbon monoxide poisoning or acute pulmonary disorders. Although rare pediatric coronary artery disease may be seen with Marfan syndrome, Kawasaki disease, Takayasu arthritis, Bulgaria, and cystic medial necrosis. Acute Mi is rare in childhood and adolescence. Adults acquire coronary artery disease from lifelong deposition of atheroma and plaque without which causes coronary artery spasm and thrombosis. Children with acute MI usually have either an acute inflammatory condition of the coronary arteries or an anomalous origin of left coronary artery. Intrauterine MI also can occur, often in association with coronary artery stenosis. Okay, prognosis. Acute myocardial infarction is associated with a 30% mortality rate. About 50% of the death occur prior to arrival at the hospital, and an additional 5 to 10% of survivors die within the first year after their myocardial infarction. Approximately half of all patients with an MI are readmitted in the hospital within 1 year of their index event. Overall prognosis is highly variable and depends largely on the extent of the infarct and the residual left ventricular function and whether the patient underwent revascularization. So better prognosis is associated with successful early reperfusion, patient arrival to fibrinolysis infusion within 30 minutes, or patient arrival to BCI within 90 minutes. Preserved left ventricular function, short-term and long-term treatment with beta blockers, aspirins, and angiotensin converting enzyme inhibitors, and poorer prognosis is associated with advanced age, diabetes mellitus, previous vascular disease like cerebral vascular disease or peripheral vascular disease, elevated thrombolysis in MI, TIMI risk score, for unstable angina and non-ST elevation acute coronary syndrome. A delayed or unsuccessful reperfusion, a poorly preserved left ventricular function, which is the strongest predictor of outcome, evidence of congestive heart failure, Philip classification 2 or more, or frank pulmonary edema, Philip classification 3 or more. Elevated BNP levels, elevated high sensitive C-reactive protein, involvement of ECG lead AVR, and depression. It has been shown that 5 baseline parameters at presentation of patients with acute MI accounts for over 90% of the prognostic prediction of 30-day mortality from acute MI. These parameters include age, systolic blood pressure on presentation, Philip classification, heart rate, anatomic location of the MI. The Philip classification is widely used in patients presenting with acute MI for the purpose of risk stratification. Philip class 1 include individuals with no clinical sign of heart failure. Class 2 includes individual with rales or crackles in the lungs, and S3 gallop and elevated jugular venous pressure. Philip class 3 describe individuals with frank acute pulmonary edema. Philip class 4 describe individual in cardiogenic shock or hypotension measured at systolic below 90 millimeter of mercury, and evidence of low cardiac output like Liguria, cyanosis, and or impaired mental status. Okay, clinical presentation. History, the patient history is critical in diagnosis of MI, and sometimes may provide the only clues that can lead to the diagnosis in the initial phases of the patient presentation. Patients with typical acute MI usually present with chest pain and may have prodromal symptoms of fatigue, discomfort, malaise in the days preceding the event. Alternatively, typical ST elevation MI may occur suddenly without warning. The typical chest pain of acute MI usually is intense and unremitting for 30 to 60 minutes. It is retrosternal and often radiates up to the neck, shoulder, and jaws, and down to the left arm. The chest pain is usually described as substernal pressure sensation that also is perceived as squeezing, aching, burning, or even sharp. In some patients, the symptom is epigastric with feeling of indigestion or fullness and gas. In some cases, patients do not recognize the chest pain. Maybe they have unusually high pain threshold or have a disorder that impairs pain perception and result in a defective anginal warning system, like in diabetes. In addition, some patients may have an altered mental status caused by medication or impaired cerebral perfusion. Elderly patients with pre-existing altered mental status or dementia may have no recollection of recent symptoms and may have no complaints whatsoever. MI most often happen in early morning hours, and the mechanism behind this is the circadian variation include the morning increase in sympathetic tone, leading to increase in blood pressure, heart rate, coronary vascular tone, and myocardial contractility. The morning increase in blood viscosity, coagulability, and platelet aggregability. And the increased morning levels of serum cortisol and plasma catecholamines, leading to sympathetic overactivity, thereby resulting in increased myocardial demand. Okay. Initial rapid evaluation should include obtaining brief history, performing focused physical examination. Important elements of history such as characteristics of pain and important associated symptoms and past history of risk factors for cardiovascular disease are used to determine the likelihood that these symptoms represent acute coronary syndrome and to predict the likelihood of clinical outcomes. Several risk assessment scores and clinical prediction algorithms are used to help identify patients with ACS at increased risk of adverse outcomes, such as TMI, which is thrombolysis in myocardial infarction risk score, the GRACE Global Registry of Acute Coronary events risk score, and the National Cardiovascular Data Registry, Acute Coronary Treatment and Intervention Outcomes Network Registry. Investigators have also proposed a novel risk scoring system that might have the potential to predict cardiovascular death in patients with acute Mi, that CHADS2 VAS CF, which is congestive heart failure, hypertension age 75 or more, diabetes, stroke, transient ischemic attack, vascular disease, age 65 to 74, and sex category. Takes into account the cigarette smoking and family history of coronary artery disease as risk factor. A high index of suspicion for MI should be maintained, especially when evaluating women, patients with diabetes, older patients with dementia, patients with a history of heart failure or cocaine users, a patient with hypercholesterolemia, and patient with a positive family history of early coronary disease. A positive family history includes first degree male relative age 45 years or younger, or any first degree female relative aged 55 years or younger who experience an MI or the need for coronary revascularization. Other symptoms of MI include anxiety, commonly described as sense of impending doom, pain or discomfort in areas of the body, including arms, left shoulder, back, neck, jaw, or stomach, lightheadedness with or without syncope, cough, nausea with or without vomiting, profuse sweating, shortness of breath, wheezing, rapid or irregular heart rate, fullness on digestion or shocking feeling. Okay. This figure shows us the cardinal and the non-specific sign of MI. In cardinal symptoms, we can see retrosternal pain radiating to the left side of the body, arm, shoulder, neck, and epigastrium, dyspnea, nausea, and vomiting, diaphoresis, sense of impending doom, and restlessness, and specific warning sign, including dizziness, lightheadedness, or syncope, fatigue, exhaustion, jaw, neck, or upper back pain, palpitation, epigastric discomfort, or pressure. Okay, physical examination. Physical examination finding for MI can vary. One patient might be comfortable in bed with normal examination results, where another patient might be in severe pain with significant respiratory distress and in need for ventilatory support. Patients with ongoing symptoms usually lie quietly in bed and appear pale and diaphoretic. Regarding vital signs, in heart rate, the patient heart rate is often increased. Tachycardia will be secondary to sympathoadrenal discharge. The pulse might be irregular because of ventricular ectopy, an accelerated idioventricular rhythm, ventricular tachycardia, and atrial fibrillation of flutter or other supraventricular arrhythmia. Depressed heart rate may be also present in some cases. Bradyarrhythmia may be because impaired function of the sinus node, an AV nodal block or infranodal block may be also present. Unequal pulses can be suggestive of the presence of aortic dissection, which is commonly present with chest pain radiating to the back, accompanied by blood pressure difference of 50 millimeter of mercury or greater between both arms, and an aortic regurgitation murmur. Regarding blood pressure, in general, the patient blood pressure is initially elevated hypertension because of the arterial vasoconstriction resulting from an adrenergic response to pain, anxiety, and ventricular dysfunction. However, it is not uncommon to have increased blood pressure as the precipitant of acute MI. Hypotension can also be seen, usually and this indicates either right ventricular MI or severe left ventricular dysfunction due to a large infarct area or impaired global cardiac contractility. And in respiratory rate, the respiratory rate may be increased in response to pulmonary congestion or anxiety. We can see fever is usually present within 24 to 48 hours, with the temperature curve generally parallel to the time course of elevation of the creatine kinase levels in the blood. Body temperature might be occasionally exceed 38 degrees. Okay. head and neck examination, we can see in patient with acute inferior MI with right ventricular involvement, distension of neck veins is commonly described as a sign of failure of the right ventricle. Impaired right ventricular function also leads to systemic venous hypertension, edema, and hepatomegaly. Cardiac examination. On palpation, lateral displacement of the apical impulse, dyskinesis, a palpable S4 gallop, and a soft S1 sound might be found. These signs indicate diminished contractility of the compromised left ventricle. Paradoxical splitting of S2 may reflect the presence of left bundle branch block or prolongation of pre-ejection period with the delayed closure of aortic valve despite decreased stroke volume. A neomaterial regurgitation murmur, typically holosystolic near the apex, indicate papillary muscle dysfunction or rupture or mitral annular dilation. It might be audible even with when cardiac output is substantially decreased. A holosystolic murmur that radiates to the mid-sternal border and not to the back, possibly with a palpable trace suggestive ventricular septal rupture. Such a rupture may occur as a complication in some patients with full thickness MI. With resistive flow and an enlarged pressure difference, the ventricular septal defect murmur become harsher, louder, and higher in pitch than before. Pericardial friction rub may be audible as to and fro rasping sound, and it's produced through sliding contract inflammation rough surfaces. In chest examination, rails or wheezes may be auscultated. This occur secondary to pulmonary venous hypertension, which is associated with extensive acute left ventricular MI. Unilateral or bilateral pleural effusion might produce agophony at the lung basis. In abdominal examination, patient frequently develops tricuspid incompetence, so hepatojugular reflex might be elicited when hepatomegaly is not marked. A basaltile abdominal mass might suggest an abdominal aortic aneurysm. In lower limb, we can see peripheral cyanosis, edema, pallor, diminished pulse volume, delayed rise, delayed capillary fill may indicate vasoconstriction, diminished cardiac output, and right ventricular dysfunction or failure. Okay. Workup. The objective of laboratory testing and imaging include determine the presence or absence of MI for the diagnosis and differential diagnosis to characterize the location, nature, and the extent of MI, to detect recurrent ischemia or MI, to detect early and late complication of MI, to estimate the patient prognosis. We use ECG laboratory tests used in the diagnosis of MI include cardiac biomarkers enzyme, the American College of Cardiology, American Heart Association, and the European Society of Cardiology guidelines recommend cardiac troponin as the only cardiac biomarker that should be measured at presentation in patients with suspected MI due to its superior sensitivity and accuracy. And troponin is a contractile protein that is not normally found in serum, and it is released when myocardial necrosis occur. Also CBC, comprehensive metabolic panel, and lastly, lipid profile. ECG. The ECG is the most important tool in the initial evaluation and triage of patients in whom ACS is suspected. Obtaining ECG by emergency medical services, personnel at the site of first medical contact in patients with symptoms consistent with ST elevation MI, not only confirms the diagnosis in more than 80% of cases, but also helps in detect life-threatening arrhythmia and allows an early defibrillation therapy if indicated. Expert medical societies and organizations, including American College of Cardiology, American Heart Association, and the European Society of Cardiology, have implemented the importance of obtaining a 12-lead ECG in a timely fashion, 10 minutes or less of presentation in their recommendation in management of ACS and STEMI. with interpretation by an experienced physician. ECG should be performed serially upon presentation to evaluate the progression and to assess changes with or without pain. Because of symptoms of acute MI might be subtle, an ECG should be performed on any patient who is older than 45 years and experiencing any form of thoracoabdominal discomfort, including new epigastric pain or nausea. In younger patients, ECG should be considered when suggestive symptoms are present or when risk factor exists for early coronary disease. So the ECG is a rapid, low risk, relatively low cost measure. Okay, different ECG abnormalities. ECG is an effective tool to distinguish between acute MI and myocardial ischemia that usually precedes it. As not all patients with myocardial ischemia will develop MI. Transitioning from ischemia to infarction results in precise substitutional electrical abnormality captured on ECG. These changes are localized, which help us in detection of the involved region of the myocardium. In most cases, in STEMI, typical ST elevation persists for hours and is followed by inversion of T wave during the first few days and by the development of Q wave. However, initial ST depression or T wave inversion associated with MI is difficult to differentiate from that seen in the presence of ischemia without MI or other unrelated condition. ST segment depression followed by T wave inversion without evolution of Q wave may result from non-ST elevation MI or from subendocardial ischemia without MI. High probability ECG features of MI are ST segment elevation greater than 1 millimeter into anatomically conditions leads, the presence of new Q wave. Intermediate probability ECG feature of MI include ST segment depression T wave inversion, other non-specific ST T wave abnormalities. Low probability ECG features of MI are normal ECG finding. However, normal or non-specific finding of on ECG does not exclude the possibility of MI. Special attention should be made if there is a diffuse ST depression in the pericardial and extremity leads associated with more than 1 millimeter ST elevation in lead FER, as this might indicate stenosis of the left main coronary artery on the proximal section of the left anterior descending coronary artery. Localization. Localization of the involved myocardium based on distribution of CG abnormalities in MI is as we can see in this figure. In yellow, you can see the inferior wall shows in lead 2, 3, and AVF, and it is supplied by right coronary artery. In green, we can see septum involvement shows in V1 and V2. In red, anterior wall shows in V3 and V4. Anterior wall and septum often infarct together because both supplied by the LAD. So anterior septum MI shows in V1 to V4. Lateral wall in blue shows in lead 1 AVL and V5 and V6 and supplied by left circ. True posterior wall MIs might cause pericardial ST depression, inverted and hyperacute T waves. Both ST segment elevation and upright hyperacute T wave might be evident the use of right-sided chest leads. Okay. The characteristic ECG changes may be seen in condition other than MI. For example, patient with previous MI and left ventricular aneurysm may have persistent ST elevation, resulting in dyskinetic wall motion rather than acute myocardial injury. ST segment changes might also be the result of misplaced pericardial leads, early repolarization abnormalities, hypothermia, or hypothyroidism. False Q wave may be seen in septal lead in hypertrophic cardiomyopathy, and they may also result from cardiac rotation. Substantial T wave inversion may be seen in left ventricular hypertrophy with secondary repolarization changes. Diffuse brain injuries and hemorrhagic stroke may be also trigger changes in T wave, which are usually widespread and global involving all leads. ST depression and T wave changes may also indicate evolution of non-STEMI. The QT segment may be prolonged because ischemia or electrolyte disturbance. Saddleback state segment elevation, Brugada epsilon weight, may be seen in leads V1, 2, 3. In patient with congenital predisposition to life-threatening arrhythmia, this may be confused with that observed in acute anterior MI. A patient with a permanent pacemaker may be confound recognition of STEMI by 12 lead ECG due to the presence of paced ventricular contraction. And to summarize, non-ischemic causes of ST segment elevation include left ventricular hypertrophy, pericarditis, ventricular-based rhythms, hypothermia, hyperkalemia, and other electrolyte imbalances, and left ventricular aneurysm. Okay, cardiac biomarkers. In the past, different cardiac biomarkers have been used to evaluate patients with suspected acute MI. The cardiac specific troponins, I and T, creatine kinase, and CKMB, the MB is isoenzyme of creatine kinase, and myoglobin, have been used surrogates for myocardial necrosis. Cardiac troponin detection and quantification has improved dramatically over the years as the advanced technology allows to obtain cardiac troponin assay running on automatic platforms, high degree of sensitivity. Serial measurements of cardiac troponin after the initial level is obtained, presentation 3 hours after symptoms onset is recommended. If initial levels are negative, additional measurements beyond the 6-hour mark should be obtained. Okay, cardiac troponin, highly sensitive assays can now detect cardiac troponin in patients with acute MI with a high degree of certainty. This has led to change in the clinical practice guidelines to recommend relying on the result of sensitive or high sensitive troponin I or troponin T assays for diagnostic and prognostication for prognosis in patients with symptoms of suggestive of MI. Serum levels increase within 3 to 12 hours from the onset of chest pain, peak at 24 to 48 hours, and return to baseline over 5 to 14 days. Measurements of troponin for patients with chest pain in the emergency setting has been studied. Baseline measurement troponin levels followed by serial measurements of troponin 3 hours afterward should be performed. Both absolute value of the troponin level as well as the degree of change in troponin level should be considered. This has been associated with better performance and accurate diagnosis of acute MI. Okay, BMB. BMB is a 32 amino acid polypeptide secreted by ventricles of the heart in response to excessive stretching of cardiomyocyte. Measurements of BMB or NT-proBNP for diagnosis of acute MI is not recommended for diagnosis of MI, but these biomarkers have utility in risk stratification and prognosis of patients with acute MI who have also congestive heart failure. Other lab studies, blood oxygenation should be checked and repeatedly corrected if any clinical findings suggest hypoxemia. Hypoxemia may result from pulmonary congestion, atelectasis, or ventilatory impairment secondary to complication of MI or excessive sedation or analgesia. We should obtain CBC count if myocardial is suspected in order to rule out anemia as a cause of decreased oxygen supply and prior to giving thrombolytic agents. Leukocytosis is also common but not universal. In the setting of acute MI, the leukocyte count might be normal initially, but it generally increases within 2 hours and peaks in 2 to 4 days, with predominance of polymorph nuclear leukocyte and a shift to left. Elevation generally persists for 1 to 2 weeks. Platelet count is necessary if a glycoprotein 2B and 3A agent is considered. The platelet count may be become also dangerously low after the use of heparin because of the heparin-induced thrombocytopenia. Comprehensive chemistry profile or comprehensive metabolic panel. In the setting of MI, closely monitor potassium and magnesium level. The creatinine level is also needed prior to cardiac cath and prior to initiating treatment of angiotensin-converting enzyme inhibitor. Blood glucose levels are important to measure, as many patients are first diagnosed with diabetes when they present with MI. Although not routinely measured, the ESR raises above the reference range values within 3 days and may remain elevated for weeks. The serum LDH level rises above the reference range within 24 hours of MI, reaches peak within 3 to 6 days and returns to baseline within 8 to 12 days. Lastly, lipid profile. Lipid profile may be helpful if obtained upon presentation because lipids can change after 12 to 24 hours of acute illness. However, regardless of the lipid profile results, initiation of high-intensity statin is recommended in all patients with acute coronary syndrome. Cardiac imaging. The role of imaging in the workup of acute MI is broad. But the procedure are primarily used to confirm or rule out coronary artery disease. Furthermore, imaging may help to define the anatomy and degree of myocardial perfusion abnormalities. In low-risk individuals in whom ACS is suspected and do not have serial ECG changes or positive serial cardiac biomarkers finding, some form of stress testing may help to confirm the diagnosis and to guide the therapy. For individual with high probable or confirmed ACS, consult with a cardiologist so that urgent coronary angiography can be performed. This procedure can be used to definitely diagnose or rule out coronary artery disease. Based on angiographic result and patient comorbidities, subsequent treatment recommendation can be made, which may include medical therapy, PCI, or coronary artery bypass grafting surgery. Multi-detector computed tomograph, MDCT, coronary angiograph may be considered as an alternative to invasive angiograph to exclude ACS when there is a low to intermediate likelihood of coronary artery disease and when cardiac troponin and ECG results are inconclusive. This imaging modality can be used in the emergency department and to triage of patients with chest pain. The use of myocardial perfusion imaging MPI with single photon emission CT SPECT or positron emission tomograph PET scanning in the emergency department for the low-risk patient has a low yield for detecting ischemia. Therefore, use of SPECT or PET scanning to diagnose MI in patients with negative serial troponin results or not diagnosis ECGs is not routinely performed. Echocardiograph is highly recommended, is required to evaluate ventricular function and wall motion abnormalities. It is also used to identify pericardial effusion, ischemic mitral regurg, and cardiac tamponade that might be complicated after acute MI. Okay, management. The first goal of for healthcare professional in management of acute MI is to diagnose the condition in very rapid manner. As a general rule, initial therapy for acute MI is directed toward a restoration of perfusion as soon as possible to salvage as much of the jeopardized myocardium as possible. This may accomplish through medical or mechanical means such as PCI or coronary artery bypass grafting surgery. Although initial treatment of different types of acute coronary syndrome may appear to be similar, it is very important to distinguish whether the patient having STEMI or non-STEMI, because definitive therapies differ between these two types of MI. Particular consideration and differences involve the urgency of therapy and the degree of evidence regarding different pharmacology options. Over the last decade, inhibition protein convertase subtyrosine cathepsin type 9 (BCSK9) has emerged as a promising target to reduce residual cardiovascular disease risk. The BCSK9 is a protein that binds with low-density lipoprotein receptors to promote their degradation. Monoclonal antibodies inhibit BCSK9 and thus prevent LR degradation. This action will increase the number of LDRs and subsequently increase the clearance of LDL, ultimately lowering LDL levels. In December 2015, FDA approved the first BCSK9 inhibitor, evolocumab or Repatha, for the prevention of strokes, heart attacks, and coronary revascularization. And this approval was based on data from evolocumab cardiovascular outcome study for a year. Okay. Guidelines. The American College of Cardiology Foundation, the American Heart Association, as well as the European Society of Cardiology have developed guidelines for management of patients with ST segment elevation and myocardial infarction. Pre-hospital care and pre-hospital emergency care, the American College of Cardiology Foundation, American Heart Association, and the European Society of Cardiology guidelines stress the importance of obtaining 12-lead ECG in a timely fashion, 10 minutes or less of presentation in their recommendation. It's class 1 for all three guidelines. The European Society of Cardiology guidelines also recommend ECG monitoring with defibrillator capacity as soon as possible in all patients with suspected STEMI. It's class 1, but do not recommend pre-hospital cooling with a rapid infusion of large volume of cold IV fluid immediately after return of spontaneous circulation, and it's class 2A. Okay, revascularization in STEMI. And this is the 2021 American guidelines for coronary artery vascularization that released last week. The immediate reperfusion therapy for patients with STEMI improves mortality rate, and primary BCI has been shown to be superior to fibrinolytic therapy. Fibrinolytic therapy is recommended only in cases in which primary BCI is not immediately available, and the delay from hospital presentation to BCI anticipated to be more than 120 minutes. Because approximately 35% of patients treated with fibrinolysis do not achieve reperfusion, and an additional 10% have ineffective reperfusion, TIMI flow grade below 3. Early transfer of patient to centers capable of performing BCI will facilitate early cath and or BCI. CABG has a limited role in acute phase of STEMI, and its use in the setting continues to decrease. Older case series have highlighted the potential excess mortality risk when coronary artery bypass grafting is performed early after ST elevation MI. However, modification to the standard operative approach, improved anesthesia and monitoring, improved technical methods, and adjunctive temporary mechanical circulatory support devices may lead to improved race survival after coronary artery bypass grafting. Okay, we see here in class 1 a recommendation for revascularization in infarct artery in patients with STEMI. Patient with STEMI and ischemic symptoms for less than 12 hours, BCI should be performed to improve survival. And patients with STEMI and cardiogenic shock or hemodynamic instability, BCI or CABG. When BCI is not feasible, it's indicated to improve survival, irreversible of time delay from MI onset, both class 1. Here, in patients with STEMI who have mechanical complications such as ventricular septal rupture, mitral valve insufficiency because of biliary muscle infarction or rupture, or free wall rupture, CABG is recommended at the time of surgery with the goal of improving survival. In patients with STEMI and evidence of failed reperfusion after fibrinolytic therapy, rescue BCI of infarct artery should be performed to improve clinical outcome. Also here, both class 1. 5. In patients with ischemia who are treated with fibrinolytic therapy, angiograph within 3 to 24 hours with the intent to perform BCI is reasonable to improve clinical outcomes. In patients with ischemia who are stable and presenting 12 to 24 hours after symptoms onset, BCI is reasonable to improve clinical outcomes. In patients with ischemia and whom BCI is not feasible or successful with a large area of myocardium at rest, emergency or urgent CABG can be effective as a perfusion modality to improve clinical outcomes. And all three of them are class 2A. Also here, class 2A, 8, in patients with ischemia complicated by ongoing ischemia, acute severe heart failure or life-threatening arrhythmia, BCI can be beneficial to improve clinical outcome irrespective of time delay from MI onset. 9, class 3 and no benefit in a symptomatic stable patient with ischemia who have totally occluded infarct artery more than 24 hours after symptoms onset and are without evidence of severe ischemia, BCI should not be performed. 10, it's class 3 also and harm, consider harm. In patient with ischemia, emergency CABG should not be performed after failed primary BCI in the absence of ischemia or a large area of myocardium at risk, or if the surgical revascularization is not feasible because of no reflow state or a poor distal target. Revascularization in non-infarct artery in patient with ischemia. In selected hemodynamically stable patient with ischemia and multi-vessel disease after successful primary BCI, stage BCI of significant non-infarct artery stenosis is recommended to reduce risk of death or MI. It's class 1. Class 2A, in selected patients with ischemia with complex multi-vessel non-infarct artery disease after successful primary BCI, elective CABG is reasonable to reduce the risk of cardiac events. 3, it's class 2B. It's selected hemodynamically stable patients with ischemia and low multi-vessel disease. BCI of non-infarct artery stenosis might be considered at the time of primary BCI to reduce cardiac event rate. Lastly, number 4, it's class 3 and harm, and patient with ischemia complicated by cardiogenic shock. Routine BCI of non-infarct artery at the time of primary BCI should not be performed because of the higher risk of death or renal failure. Okay, this table for the patient clinical status definition to guide revascularization. In elective, the patient cardiac function has been stable in the days or weeks before intervention, whether surgical or procedural. The intervention could be deferred without increased risk of compromise to cardiac outcome. Urgent intervention is required during the same hospitalization to minimize chance of further clinical deterioration. Examples include worsening sudden chest pain, heart failure, acute MI anatomy, and intra-aortic balloon pump and stable angina with IV nitroglycerin or rest angina. In emergency, patient required emergency intervention when have ongoing refractory, difficult, complicated, or unmanageable, unrelenting cardiac compromise with or without hemodynamic instability and not responsive to any form of therapy except cardiac intervention. An emergency intervention is one in which there should be no delay in providing operative intervention. Lastly, emergency or salvage. A patient required emergency salvage intervention are those who require cardiopulmonary resuscitation en route to the operating room or procedure room before induction of anesthesia, or who require extracorporeal membrane oxygenation to maintain life. Okay, and this is the 2018 European Society Cardiology Guidelines on myocardial revascularization. Myocardial revascularization in patients with STEMI is addressed by the 2017 European guidelines on STEMI. After reviewing the subsequent literature, the current task force endorsed most of recommendation of these guidelines. So the indication, reperfusion therapy is indicated on all patients with time from onset less than 12 hours, duration with persistent ST segment elevation. In absence of ST segment elevation, a primary BCI strategy is indicated in patients with suspected ongoing ischemic symptoms suggestive of MI, and at least one of the following criteria are present: hemodynamic unstable or cardiogenic shock, recurrent or ongoing chest pain, refractory to medical treatment, life-threatening arrhythmia, or cardiac arrest, mechanical complication, heart failure, recurrent dynamic ST segment or T wave changes, particularly in intermittent ST segment elevation. A primary BCI strategy is recommended over fibrinolysis within the indicated time frames. In patients with time from symptom onset more than 12 hours, a primary BCI strategy is indicated in the presence of ongoing symptoms or signs suggestive of ischemia, hemodynamic unstable, or life-threatening arrhythmia. A routine BCI strategy should be considered in patients presenting late, from 12 to 48 hours after symptom onset, and this is class 2A. And logistics, it is recommended that the pre-hospital management of STEMI patients should be based on regional networks that are designed to deliver reperfusion therapy effectively in a timely fashion and to offer primary BCI to as many patients as possible. It is recommended that all EMS, emergency department, coronary artery, coronary care units, and cath laboratories have a written updates STEMI management protocol, preferably shared within geographical networks. It is recommended that primary BCI capable center deliver a 24-hour 7-day service to ensure primary BCI is performed as fast as possible. It is recommended that patients transfer to BCI capable centers for primary BCI bypass the emergency department and CCU and are transferred directly to the cath laboratory and all class 1. Here, BCI for myocardial reperfusion ST elevation MI, procedural aspects, strategy and techniques, routine revascularization of non-infarct-related artery lesion should be considered in patients with multi-vessel disease before hospital discharge, is class 2A. CABG should be considered in patients with ongoing ischemia in a large area of necrotized myocardium if BCI of the infarct-related artery cannot be performed. It's also class 2A. And in class 3, in cardiogenic shock, routine revascularization of non-infarct-related artery lesion is not recommended during primary BCI. Routine use of thrombus aspiration is not recommended. It's class 3. Okay, revascularization in LST segment elevation, acute coronary syndrome. This is also the 2021 guideline, American guideline for coronary artery revascularization. A routine invasive approach for patients with non-ST elevation ICS is associated with improved outcomes. Risk stratification is validated score, GRACE or STEMI, has been recommended to guide the timing of coronary angiography. The GRACE 2 risk calculator has been used in most clinical trials to identify patients who are at high risk of death or MI, and it enables directed estimation of mortality risk during hospitalization and at 1 and 3 years. A GRACE score of more than 140 has been used to donate a patient at higher risk of clinical events. Other factors associated with high risk include older age, more than 75, elevated TIM risk score, and elevated cardiac markers. Factors indicating a need for urgent revascularization with either BCI or CABG include threatening anatomy, ongoing ischemia, and hemodynamic compromised. In such patient and those with complex coronary artery disease, treatment should be individualized and involve a heart team discussion. So, in the recommendation in patients with non-ST elevation SAS who are at elevated risk of recurrent ischemic events and are appropriate candidates for revascularization, and an invasive strategy with intent to proceed with revascularization is indicated to reduce cardiovascular events in patients with non-ST elevation SAS and cardiogenic shock who are appropriate candidates for revascularization. Emergency revascularization is recommended to reduce risk, both class 1 and 3, also class 1, in appropriate patient with non-ST elevation SAS have refractory angina or hemodynamic or electrical instability, and immediate invasive strategy with intent to perform revascularization is indicated to improve outcome. In patients with non-ST elevation SAS who are initially stabilized and are at high risk of clinical events, it is reasonable to choose an early invasive strategy within 24 hours over a delayed invasive strategy. In patients with non-ST elevation SAS who are initially stabilized with and are at intermediate or low risk of clinical events, an invasive strategy with intent to perform revascularization is reasonable before hospital discharge to improve outcome, both class 2A. Sixth, in patient with non-ST elevation SAS who have a failed PCI and have ongoing ischemia, hemodynamic compromise, or threatened occlusion of an artery with substantial myocardium at risk, who have are appropriate candidates for CABG. Emergency CABG is reasonable. It's class 2A also. Lastly, in patient with non-ST elevation SAS who present with cardiogenic shock, a routine multivessel PCI of non-culprit lesion in the same setting should not be performed and considered class 3 and half. And the 2018 European guidelines on myocardial revascularization, also an invasive strategy has become the standard of care for high-risk patients. This approach allows a prompt diagnosis of the underlying coronary artery disease, identification of the culprit lesions, guidance for anti-thrombotic. Management and assessment of the suitability of coronary anatomy for PCI or CABG. Regarding the timing of angiography and intervention, the current recommendation of timing of angiography and intervention are based on evidence discussed by the prior guidelines on non-ST elevation SAS, especially a reduction in recurrent or refractory ischemia and length of hospital stay was found with early intervention. So urgent coronary angiograph less than 2 hours recommended in patient with very high ischemic risk, an early invasive strategy less than 24 hours recommended in patient with at least one of high risk criterion. An invasive strategy less than 72 hours after first presentation is indicated in patient with at least one intermediate risk criterion or recurrent symptoms. It is recommended to base the revascularization strategy when needed culprit lesion PCI or multivessel PCI or CABG on the clinical status and comorbidities, as well as the disease severity. For example, the distribution of angiographic lesion characteristic or a syntax score according to the principle of stable coronary artery disease. It's all class 1. Lastly, in cardiogenic shock, routine revascularization of non-infarct related artery lesions is not recommended during primary PCI, and it is class 3. Okay, mechanical security support. The following organization released guidelines for utilization of mechanical security support: Society for Cardiovascular Angiography and Intervention, American College of Cardiology, Heart Failure Society of America, and Society for Thoracic Surgeons, International Society of Heart and Lung Transplantation, American Heart Association, and the consensus statement include a clinical expert statement by the organization noted that historically the intra-aortic balloon pump and extracorporeal membrane oxygenation device has been the only mechanical security support devices available to clinicians. But axial flow pumps such as Impella and left atrial to femoral artery bypass pumps such as tandem heart have more recently entered clinical practice. The consensus based recommendation include percutaneous circulatory assist device provide superior hemodynamic support compared with pharmacologic therapy, which is particularly apparent from the Bella tandem heart devices in those with cardiogenic shock and who fail to stabilize or show signs to improvement after initial intervention. Consider early placement of an appropriate mechanical circulatory support. In patients with cardiogenic shock, continuous flow pumps like Impella or tandem heart are more likely to provide clinical benefit than intra-aortic balloon pump. ECMO might provide a particular benefit for patients with impaired respiratory gas exchange. Consider mechanical circulatory support for isolated acute right ventricular failure that is complicated by cardiogenic shock. Consider mechanical circulatory support in the setting of high risk BCI like a multivessel left main or last patent conduit intervention, particularly if the patient is inoperable or has severely decreased ejection fraction or elevated cardiac filling pressure. Consider mechanical circulatory support in patients who fail to wean off of cardiopulmonary bypass. Consider early mechanical circulatory support in patients with acute decompensated heart failure who continue to deteriorate despite initial interventions. Mechanical circulatory support may be necessary in the setting of severe biventricular failure via both right and left-sided percutaneous devices or veno-atrial ECMO. However, this was insufficient evidence. There was insufficient evidence regarding the routine use of mechanical circulatory support as an adjunct to primary revascularization to reduce reperfusion injury or infarct size in patients with large acute Mi. The International Society for Heart and Lung Transplantation guidelines and its guidelines for mechanical circulatory support. The International Society for Heart Lung Transplantation recommend long-term mechanical circulatory support for acute cardiogenic shock in the following patient settings. It's class 2A. When ventricular function is deemed unrecoverable or unlikely to recover without long-term device support, severely ill or unable to maintain normal hemodynamics and vital organ function with temporary mechanical circulatory support or cannot be weaned from temporary mechanical circulatory support or inotropic support, has the capacity for meaningful recovery of organ function and quality of life, absence of irreversible end organ damage. Additional recommendation, and we have also here additional recommendation include, if possible, delay a permanent mechanical circulatory support in the setting of an acute infarct involving the left ventricle apex. It's class 2B. Perform echo as part of the pre-operative assessment and routinely at the regular post-operative interval to evaluate for signs of myocardial recovery and optimal mechanical circulatory support device function. This imaging modality may be used to set optimal pump parameter, and it's class 1. In addition, perform echo to evaluate suboptimal mechanical circulatory support device function or in the presence of clinical signs of circulatory dysfunction, including congestive or low output symptoms, and it's also class 1. Okay. As just a quick recap, myocardial infarction, the epidemiology, male to female 3 to 1. It affects approximately 1.5 million cases of myocardial infarction per year in the US. Etiology include rupture of unstable atherosclerotic plaques with subsequent thrombosis or partial obstruction of coronary arteries. The risk factors include non-modifiable geographic origin, age, sex, family history, genetic deposition, elevated lipoprotein, familial hypercholesterolemia, and modifiable risk factors include psychosocial factors like stress, lifestyle factors like smoking, unhealthy diet, lack of exercise, pre-existing condition like diabetes, hypertension, chronic inflammation, lipidemia, increased LDL or decreased HDL. Symptoms include cold, sweat, pallor, unrest, anxiety, vertigo, radiating chest pain or crushing chest pain, dyspnea, epigastric pain, nausea, vomiting. The diagnosis can be made in ECG, STEMI, you can see ST elevation, then STEMI, ST depression, and or T wave inversion. Laboratory studies include raising of troponin, T and I in contrast to angina. CKMB shows the extent of cell damage, BMB, myoglobin, coronary angiograph or echo. And management in STEMI, emergent coronary angiograph to BCI, ideally door to BCI, should be in less than 90 minutes. It should not exceed 120 minutes. Thrombolytic therapy, TPA, retibalase, streptokinase, and non-STEMI depending on the risk revascularization within 72 hours. Complications include cardiac death, arrhythmia, left heart failure with pulmonary edema, ruptures of the cardiac wall with cardiac tamponade, cardiogenic shock, heart failure, ventricular aneurysm. And these are my references. Thank you.
Thank you, Faris. It's one of the greatest brainstorming lectures I've heard. So does anyone have a question?
I don't know if Dr. Musab are with us.
Oh. Okay, so no questions?
Okay, شكرا يعطيكم العافية.
No. Okay, I'm not sure. Zahra, do you want to start the second lecture or you want to take a break? It's your call.
Yeah, hello everyone. I think we can take a 5-minute break and then we'll start the second or the third lecture about the journal club with Tasneem. Is that okay with Tasneem? Is she around?
Yes, it's fine.
Yeah, okay, 5 minutes and we'll come back. All right, everyone. Our last lecture of the day is Journal Club about the syntax trial. Will be presented by Dr. Tasneem Bilkhiour. Dr. Tasneem, whenever you're ready, please share your slides.
Can you hear me?
Yes.
Okay, assalamu alaikum everyone. My name is Tasneem Bilkhiour. I'm R1 at King Faisal Specialist Hospital and Research Center in Riyadh. Today I'm going to talk about the syntax trial. So the objective of the study was to assess the optimal revascularization strategy for patients with previously untreated three-vessel or left main coronary artery disease, and define the populations of patients for whom only one revascularization method will be effective. The study design was a prospective randomized controlled trial conducted in 85 sites, approved by the IRB at each center. It was sponsored by Boston Scientific. The inclusion criteria for this study was it was an all-comers enrollment of patients with previously untreated three-vessel or left main coronary artery disease or both. For the exclusion criteria, they excluded any patients with previous intervention, acute MI, or concomitant surgery. The sample size was 4,337 were screened. However, they included 3,075, 1,800 were randomized, 897 randomized to cabbage, and 903 randomized to PCI with drug-eluting stent. So this shows the included patients and the reasons for exclusion. For example, they were ineligible for some patients had treatment preferences or declined the procedure. Cardiologist, interventional cardiologist, and the cardiac surgeon examined all these patients. And for the patients with only one preferred revascularization method, they were enrolled in a parallel nested registry. So the data collection was between March 2005 through April 2007. It was in the United States and different countries in Europe. The primary endpoint was a 12-month major adverse cardiovascular and cerebrovascular events that include death, MI, stroke, and repeat revascularization. So these were the baseline characteristics of the patients. It was similar in both groups. However, in the blood pressure of more than 130 systolic and 85 diastolic, it was higher in the PCI group, as well as for the triglyceride and HDL cholesterol. It was for the triglyceride, it was more higher in the cabbage group, and also for the HDL cholesterol. The time of the procedure from randomization to the procedure was higher in the cabbage group. The primary outcome of MACE at 12 months was lower in the cabbage group with statistically significant p-value. The secondary outcome of repeat revascularization at 12 months was significantly higher among patients with PCI, with statistically significant p-value as well. The stroke rate was higher in the cabbage group compared to PCI. The rate of death was greater in PCI with statistically significant p-value. The 12-month rates of asymptomatic angiographically confirmed graft occlusion in the CABG group and the stent thrombosis in the PCI group were similar. So the outcomes according to the syntax score in the CABG group, it was similar rates of MACE at 12 months in low, mid, intermediate, and high scores patients. However, in the PCI group, MACE was significantly increased with the high syntax score. They've done subgroup analysis for patients with left main disease and three vessel disease. For the left main disease subgroup, MACE at 12 months was similar between the CABG and PCI group. Repeat revascularization was higher in the PCI group. And for the stroke, it was higher in the CABG group with significant p-value. For the other subgroup analysis of patients with three vessel disease with no left main disease, the MACE was higher in the PCI group. Repeat revascularization was higher as well in the PCI group. Any cause of death, stroke or MI was similar between CABG and PCI. So this summarizes the findings of their study. So for the discussion, the primary endpoint, which was MACE at 12 months, the non-inferiority of PCI compared with CABG was not demonstrated, mainly because of the increased repeat revascularization rate at the PCI group. So at this point, the CABG proved to be superior. So as I mentioned, the repeated revascularization was higher in the PCI group. However, it did not translate in significant overall increase in the rate of death or MI. The completeness of revascularization, the rate of complete revascularization was lower in both treatment groups. The limitations of this study was the need of long-term follow-up of the outcomes. The use of medications were different between the two groups, so the standard of care between the two groups is varied. And more patients withdrew from the CABG group compared to the PCI group. Although randomization was conducted in a blinded manner with clinicians and participants unaware of future treatment assignments, it was not possible to blind the performance of the treatment. Another limitation is the definition of MI in this study was the surgical definition, which is a new T wave in ECG. Association with a value of creatinine kinase that was 5 times the upper limit of the normal range, which may have been resulted in less severe cases if MI being overlooked. So the conclusion was CABG as compared with PCI is associated with a lower rate of MACE at 1 year among patients with three vessel or left main coronary artery disease or both, and should therefore remain the standard of care for such patients. This is my references. Any questions?
Thank you, Tasneem. Anyone has anything to add or any questions about the syntax trial? Well, it seems like no one has any questions, so that brings us to the end of today's lectures. Thank you everyone for attending and listening. See you next week.